Hello, good morning, and welcome to everyone to today's discussion about local anesthesia. What is local anesthesia and what is local anesthetic? From this discussion, we can learn about the local anesthesia and different type of local anesthetics and their structure and molecular action, pharmacodynamics, pharmacokinetics, and their indication and contraindication and adverse effect and management also. What is local anesthetic? Local anesthetic is induced reversible loss of sensation in a specific area without loss of consciousness. Local anesthesia is first used in 1984 from cocaine leaves. It is produced from cocaine leaves. Then gradually invented the procaine and lidocaine. In this picture, we can see the historical background of local anesthesia. Cocaine is first local anesthetics, which comes from cocaine leaves. It was stimulatory effect, that's why it was used primarily as a local anesthetics. And the first test was done in eye of the frog and guinea pig, and the result shows that the eye was anesthetized, and then human trial is given. What first local anesthetics comes from cocaine leaves. Cocaine leaves was found in the Western America, and in 1984, the scientists shows that the cocaine leaves acts as a stimulatory effect, and it has also the sensitive loss effect. That's why cocaine was first used as local anesthetics. In case of local anesthesia, there was two ends. One was aromatic lipophilic end, and another was amine hydrophilic end, which was linked by intermediate chain, that was amide chain or ester chain. Local anesthetics was classified according to their intermediate chain, which linked the amine hydrophilic end and lipophilic end according to their structure. Local anesthetic was classified into ester groups or amide groups, where the hydrophilic and lipophilic ends was linked by amide group, amide, then it is called amide group, and or it is where life-threatening hydrophilic agent was linked by ester, that is called ester groups. Example of the ester groups are procaine, tetracaine, chloroprocaine, etc. Amide group are oleurocaine, bupivacaine, ropivacaine. If we classify the local anesthetic as according to their duration of action, three classification. There is short acting, which acts as 15 to 30 minutes only. Procaine, chloroquine, etc. Medium acting. That was lidocaine, mepivacaine, which acts as 45 to 1 hour and 30 minutes. And long acting local anesthetic, which acts from 1 hour and 30 minutes to 2 hours and 30 minutes, up to 4 hours also. Aromatic basis of classification, in which basis amide group and ester groups was classified. Amide group we can also discuss in before that amide group lipophilic int and hydrophilic int is linked by amide linkage. Amide local anesthetics are metabolized by liver enzyme primarily by the cytochrome P450 system. That's why amide group, in case of hepatic impairment patient, amide group may cause harmful for the patient. In case of ester groups of patient, ester groups of the local anesthetics, aromatic and hydrophilic and hydrophobic lipophilic ints was linked by ester. That's why it is called ester group of local anesthetics. Ester group of local anesthetics was hydrolyzed by the plasma pseudocholinesterase. That's why if there was deficiency of plasma pseudocholinesterase, there may be delayed or delayed excretion of the ester group of local anesthetics. According to duration of action, short acting, intermediate acting, and long acting. Short acting is onset of action is very rapid and duration is 30 to 60 minutes, such as cocaine, decane, etc. Intermediate acting onset is moderate. After few minutes, it starts to act, and duration is 1 to 3 hours. Can be extended with epinephrine and many other adjuvants also. Example, lidocaine, mepivacaine. Long acting. This is slow onset of action, and the duration of action is more 2 to 5 hours. Maybe act in local anesthetic, long acting local anesthetics. Example, bupivacaine, levodopa, etc. How the local anesthetics acts. Non-ionized local anesthetic cross membrane. Ionized local anesthetic cannot cross the cell membrane, and non-ionized local anesthetic cross the cell membrane, and there in the cell, within the cell it was further ionized and binds with the voltage gated sodium channel and blocks the sodium channel. When the sodium channel was blocked, their depolarization does not occur. So it blocks the action potential, and that's why sensation is lost. In this picture, we can see the how local anesthetics acts. Pharmacodynamics and pharmacokinetics. Onset influenced by pK. Lower pK agents, such as lidocaine, are faster acting, where the pK is lower and the action is faster. And potency is correlates with the lipid solubility. Lipid solubility and protein binding. Protein binding and lipid soluble local anesthetics adds longer duration of action. Systemic absorption and toxicity, it's mainly depends on absorption of the local anesthetic by the blood vessels, and if the accidentally local anesthetic is bolus dose of local anesthetic is accidentally injected in the vein or artery, then systemic toxicity, local anesthetic systemic toxicity may occur. There are many formulations of local anesthetics, such as solutions like lidocaine, bupivacaine, creams like EMLA, eutectic mixture of local anesthetic. It is the mixture of lidocaine and procaine. Gels like many other gels we can found in the market also. Injectable forms. Injectable forms is maybe plain or with adjuvant, such as with epinephrine or plain local anesthetics. Spray also. Use of local anesthetics. What are the indication of local anesthetics? Local anesthetics blocks the nerve impulse, and that's why loss the sensation of the operation field. So in minor procedure, we can use the local anesthetics. In major procedures like cesarean section, we can also use local anesthetics. In case of regional, any kind of regional anesthesia, we use the local anesthetics. For pain management, we can use local anesthetic. In regional anesthesia, neuroaxial anesthesia, peripheral anesthesia, also we use local anesthetics. What are the contraindications? In such situations where we will not use the local anesthetics due to their moderate to severe adverse effect. If any allergy to the local anesthetics of a patient, we will not use the local anesthetics. Inflamed or infected tissue area will not inject the local anesthetics because it can spread out the inject, or if we inject in the inflamed or infected tissue, infection may be embedded with needle. In case of this specific patient, we will not use local anesthetic, such as malignant hyperthermia, pulmonary stress deficiency. Certain medications may interfere with local anesthetics or local anesthetics like beta blocker. Look how local anesthetic acts in nerves. Smaller and myelinated fiber block before larger motor touch fiber. Smaller and myelinated fiber blocks first. Smaller and myelinated fiber blocks first. Pain and temperature sensation is lost first. Then the motor and touch sensation. In case of local anesthesia, local anesthetics or local anesthesia, recovery occurs in reverse order. That means in a certain period of time, local anesthesia, recovery of the local anesthesia occurs spontaneously. Clinical techniques and additives. Infiltration, nerve blocks, topical epidural, spinal anesthesia, we can use local anesthetic. Look, in case in any adjuvant, we use with local anesthetic to for their potency for increase their potency and the duration of action, such as epinephrine and etc. There are some temporary adverse effect may be found in all of the local anesthetic, which is temporary and maybe recovered spontaneously after a certain period of time. It is not fatal for life, such as blurring of vision, tinnitus, vomiting, headache, dizziness, muscle twitching, continuous numbing, etc. It is most common in many patients and recover spontaneously. Uh, we will have to support the patients in a certain period of time. If the local anesthetic is in bolus dose, we can accidentally inject in the artery or nerve. Severe local anesthetic systemic toxicity may occur. How can we how can we diagnose the systemic local anesthetic toxicity? At first, we will see the patient. Patient will talk to the doctor. There is circumferal numbness, which starts from mouth, circumferal numbness, metallic taste, and slurring of speech. And then altered central nervous system, that is drowsiness, dizziness, arrhythmia, restlessness, convulsion. And chronologically, the patient may complain blurring of vision, lacrimation, and then tinnitus, vertigo. After then, patient will develop tonic-clonic seizure. And last of all, in of neurogenic toxicity, there is convulsion, generalized convulsion of the patient. After neurogenic toxicity, there also may develop cardiotoxicity of the local anesthetic. We can, if we see the patient, will found the extreme bradycardia, such as 20, 25 or 30, and blood and volume of the pulse is very low and hypotension, and finally cardiac arrest may occur. In this case of local systemic local anesthetic toxicity, we will have to manage promptly, and we will also help can take help from the seniors. We must have to know the manage the system local toxicity management of the systemic toxicity management of the local anesthetics. In this situation, we will call for help. We can help from our doctors or surroundings expert person in this situation, and airway management and ventilation, and in where the circulation is very low, we will bolus of bolus saline, IV infusion, and atropine, adrenaline, and also inotrope may be also used. In case of cardiac arrest, why cardiac arrest is the last stage of the systemic local anesthetic toxicity, we must have to mind that may need the CPR and adrenaline also, and may also manage in the patient in the ICU. Local LAST, local anesthetic systemic toxicity. In case of local anesthetic, what are this is the algorithm of management in which stop the injections. This is the first work, and call for help and start the IV infusion and vasoconstrictor drugs and cardiopulmonary bypass and cardiorespiratory support may also. Lipid emulsion is the only specific treatment for the local anesthetic systemic toxicity. Here, if the patient is more than 70 kg or less than 70, it is more than 70, the bolus 100 ml over 2 to 3 minutes. If the patient is less than 70 kg, bolus 1 to 5 ml per kg over 2 to 3 minutes. At first, we will infuse. Then infuse 200 to 250 ml over 15 to 20 minutes. In case of less than 70 kg of weight, after 2 to 3 minutes, we will infuse 0.25 ml per kg per minute of the body weight. In association with the lipid emulsion, we will also use, according to the sign symptom of the patient, vasoconstrictive drugs and control of the seizure, cardiorespiratory and cardio support, and a patient may also have to manage in the intensive care unit.